Recording in progress.
Good evening. Good evening to one and everyone. First of all, let me start by wishing you all a very happy New Year 2022. On behalf of Sun Pharma, I welcome you all for today's scientific webinar on Molnupiravir. Is it a game changer in management of COVID-19? So the topic today that we have selected is based on today's requirement in the current scenario of COVID-19. We have seen in the last 1.5 years how COVID-19 has progressed. We saw the first wave, the second wave, and now again from December 2021, the cases have again been rising. But however, along with that, the armamentarium for the management of COVID-19 has also progressed a lot. So now there are multiple options in the management of COVID-19, right from the milder stages to the severe stages. Earlier, we saw that there were very limited treatment options for the mild diseases. But to discuss more on this and also looking at the current recent advances in terms of the launches as well as the availability of the newer molecules, including Molnupiravir, we have with us an expert team of Dr. Murli Mohan sir, Dr. Sanjeev Mehta sir, Dr. Ashok Mahashur sir, and Dr. Suryakant sir. Without taking much time, I will hand over the session to our moderator, Dr. B.V. Murli Mohan sir. So before I hand over the session, let me introduce our moderator for today's session, Dr. B.V. Murli Mohan sir. Sir is MD, MRCP, SE and from UK and FRCP from Glasgow. Sir is a senior consultant pulmonologist in the departments of internal medicine pulmonology at Narayana Hrudyalaya, Bangalore. Now I will request Dr. Murli Mohan sir to take over the session. And before starting it, may I request sir to introduce all the other panelists.
Thank you, Dr. Chaudhary. We are indeed very lucky to have two experts from Mumbai on the panel, and of course, Dr. Suryakant Tripathi. Our speaker for today, who's going to introduce the whole topic as well as speak to us on Molnupiravir, is a good friend, Dr. Sanjeev Mehta. Unfortunately, thanks to COVID, we've not met for some time, but we keep meeting online. Dr. Mehta is an MD and FCCP, a consultant in chest, allergy and sleep medicines at the Leelavati and Arogyanidhi hospitals in Mumbai. He's a founder of the Lung India Foundation Life, which I'm proud to be a member of, a founder of the Mumbai Chess Group, a founder state chairman of the Indian Chess Society, and more than anything, he's one of the best known pulmonologists and best known speakers in the country. We look forward to hearing Dr. Sanjeev Mehta, and you'll never be disappointed by him. Our second panelist, Dr. Ashok Mahashur, needs no introduction at all to anyone in the country. He's one of our senior most chest physicians in the country, truly loved by his students, by people who worked with him, and people like me who've had the good fortune to be associated with him on various CMEs and other programs. He brings a wealth of experience, a wealth of knowledge, and his own inimitable personality, well-loved personality. So welcome, Professor Mahashur. Professor Mahashur is a consultant chest physician at PD Hinduja Hospital now, but that doesn't do him justice. He's so much more than that. Our third panelist, I'm not sure if he's joined us yet, but I think he will be joining us soon, is Professor Suryakant Tripathi, again, a very loved teacher and pulmonologist. Dr. Suryakant is a professor and head of the Department of Respiratory Medicine at the King George Medical University, Lucknow, and the PGI there. He's the National Vice Chairman of the IMA-MS, and he's been a past president of all our major pulmonology organizations, the Indian Chest Society, the NCCP, and the Allergy Asthma Association. So I will not take up more time, but Dr. Suryakant Tripathi is again a very good friend and a wonderful speaker in more than one language. So very fortunate to have this group. Fortunate not only in their knowledge, but also in their experience of COVID-19 and of Molnupiravir. COVID-19, as you know, seems to take origin, we're not talking about the origin of the virus, which was in China, but the origin that we have experienced, the disease itself comes mostly from Mumbai. Mumbai is where it all starts, and then it spreads to the rest of the country. So we've always leaned on the pulmonologists and physicians from Mumbai, Dr. Mehta and others, Dr. Zeri Rudwadia, Professor Mahashur, Dr. Shashank Joshi, and we've gained from their valuable experiences. So we're a little better armed when we go forward to treat it in our own places. We faced that in the first wave, the second wave, and hopefully we'll have their experiences before we get hit hard by the third wave, which is already starting in all parts of the country. The other things that we will be discussing, apart from COVID-19 in general, is the new variant, Omicron, which seems to be creating waves across the world. What it's really going to mean in terms of the pandemic is not very clear, but hope we'll get some clarity during the discussions. And finally, and most important, we will be discussing one of the newer molecules that's available, Molnupiravir, and asking ourselves, is it a game changer in the management of COVID-19? So with no further wasting of your time, and I believe we have more than 1,000 people logged in, and that's amazing because, you know, there's another seminar starting very soon. In fact, I think there's more than one seminar on Molnupiravir starting very soon. To have more than 1,000 logins is truly humbling for me. I will invite Dr. Sanjeev Mehta to take us through the discussion on Molnupiravir. Is it a game changer? Sanjeev, over to you.
Thank you very much, Murli. It's always a pleasure to see you. Till we meet virtually is good enough, and then hopefully we'll meet soon. I just wonder what will happen to the NAPCON that is supposed to be around the corner. With the surge going on, that is something we'll all have to come to terms with sooner rather than later. But again, thank you very much for the kind introduction. It's always a pleasure to be introduced by your friend. You say all the nice things, which I don't know all of them being true, but you're extremely kind. So, Murli, thank you very much. I'd like to thank Akash and his team from Sun for inviting me here, for giving me this opportunity. And of course, it's a pleasure to see Dr. Mahashur and hopefully Dr. Suryakant. And I'm sure I'll learn a lot in the discussions that follow. I have to admit, this molecule is new for me, but let's see what we can learn. Let's see. So can I share the screen? Are you guys seeing? Are you seeing it?
Yes, sir, we are.
Yeah.
So again, thank you, and let me start with the discussion on this disease and molecule. So you can see from this extremely horrendous slide that this virus is on the move. So, every time we think that now this disease is gone and life starts to come back to the new normal. I can't say it was the normal, but the new normal. And then, boom, it hits us again. We saw that in the first wave. In fact, now it's difficult to make out which wave ended where. But realistically, at least in India, we had a wave, say, in August of last year, August, July, September. Then we seemed to get better, and then we got hit by a terrible second wave. And now the world is getting hit by a third wave. In fact, just day before yesterday, in the world had the maximum number of COVID infections ever in the pandemic. And all of us who thought that this pandemic is going down got really hit by this reality that it's far from going away. It's actually hit the maximum number of cases ever just 2 days ago. In fact, I looked at the numbers in the US, and they were 4.5 lakh cases in one day. UK, about 1 lakh. Europe, countries like France and others, about 1 to 1.2 lakhs. So really, this disease is far from going away. Our numbers have gone up, double, tripled in the last 1 week. I don't know where it'll end. Let's hope that it will soon. In India, we've had more than 3 crore cases. Fortunately, very few deaths. If you look at the bottom part of this slide, this is the number of deaths per million, and you'll see that India has had the lowest deaths per million in the world, which is basically because we have many millions. So this is the number of patients we've had, and the numbers will ultimately keep rising. We don't know where it'll end. So we need to be able to deal with this disease. This is the Indian, shall I say, calculus or data. More than 34 million diagnosed. Fortunately, not too many, only 5% of the 34 million needed to be in hospital. That's yet a very large number. Fatality rate is only 1%. So that's a good sign. But you never know when. So, for those who say, oh, this mutation is mild, you never know when it can have a bad mutation like Delta. And if that happens, it may be a big problem. So, well, what are the strategies that we have had to deal with this virus? So, I think key to everything is active immunity. And for that, vaccinations have been at the forefront. I'm proud to say that India has had one of the best vaccination record given the population. We have 1 billion people spread in the lowest part. So given the population, which is like Mumbai, 100% in most areas, second vaccine significantly done, 80%. So active immunity is going to form the major thrust. And I'm sure over time, we're going to get second and third modifications like the influenza. There'll be new COVID vaccines. But that's not enough. Active immunity wanes. To supplement active immunity, there is passive immunity. So we've had initially the convalescent sera, but I think that's now things of the past. Now we have monoclonal antibodies, and I think these will have to be modified over time, but that's what we have. And I think these are making a difference. What has been with us, what continues to be with us, are supportive management that have, in fact, in the initial part, you remember we had nothing. It was just a supportive care. So steroids, anticoagulants, oxygen, ventilators, antipyretics, of course, possibly anti-IL-6 medicines for whatever they did, and other medical support. So this has essentially been the mainstay of management, along with antivirals. So we started with the first antiviral that came to us a couple of months into the disease, and that was remdesivir. It's been used. A lot of people have questioned whether remdesivir, its utility, but I think even as much as just last week, there was a study that showed that there was significant benefit, particularly in the hospitalized patient. The problem with remdesivir is that it's an injectable. And I think because it's an injectable, it was labeled for use only in hospitalized patients. So there was a big gap for a long time as to what do you do when the patient becomes sick in the community. And a couple of months ago, there was a drug that was introduced. It's yet there with us, Molnupiravir. Now, there are a lot of questions. Good drug to start with, but high dose, inconvenient, and what was a percentage of efficacy was something that had been, open for discussion. And I'll have a slide on that in the end, and we can look at whether that was, what the efficacy was or is. What is now happened is, so this is the way we understood it. Early viral phase, patients would get the diagnosis, mm, favipiravir, neutralizing antibodies. These are the ones which are available right now. And then, of course, in the inflammatory phase, the patient, if he became hypoxic, gets remdesivir, gets steroids, gets low molecular weight heparin, gets supplemental care. And of course, if the patient got worse, then invasive ventilation. Now, this is the flow that has been discussed, and I won't go into detail. I'm going to focus on the new molecule, which is molnupiravir, and this is fills a gap, and that is an antiviral that can be used in the early phase of the infection. Um, so let's look at this molecule. Now, this is an oral prodrug that gets converted into the active NHC form. What that does is it becomes a substrate in the triphosphatase form for the viral RNA polymerase. Basically, what NHC does is it fools the virus into substituting it in any of these forms into the uridine triphosphate and the cytidine triphosphate. Basically, you understand that what is happening is that the virus starts to incorporate this these molecules instead of the DNA that builds it. So the uridine and the cytidine bases. Now, when that happens, obviously the molecule, the DNA and the RNA molecule, which is formed, will be defective because it doesn't have the original bases. And when it does not have that and it is defective, now the virus that does form from this defective RNA chain then becomes inefficient. When it becomes inefficient by this step of incorporation, what gets created is a defective virus which will not multiply as well as it would. A, when it does multiply, it makes lesser copies. So immediately that will go down. So infectivity goes down. And what gets produced will be easily destroyed by the immune system. So it's a defective virus. So this seems to be great in principle. The question that's going to be asked is, does this really happen in practice? So let's look at some of the studies that were done, basis of which ultimately this drug has been approved both in Europe and in USA. So this study that was done showed, now this is, I'm just trying to see where it was presented. I'm not able to tell you where it was presented. I'm sorry, I'm trying to get the reference to it. But what this study does is it shows that this NHC, the active form of molnupiravir, displays an antiviral activity across all SARS-CoV variants. So this study was done when the various variants were circulating, the alpha, beta, gamma, delta. Against all the variants, this molecule works. And one second.
Dr. Sanjeev, I think this was one of the early studies, if I remember right. Yeah, one of the phase 2 studies.
Phase 2, yeah. This is a phase 2 study. I'm just trying to get where it published, but be what it may, the data is very strong that it inhibits the replication of the entire set of variants of concern. This is the wild form, and these are all the variants, and it is equally effective in preventing the replication. I have more studies after that. So you can see that across the wild form, alpha, beta, in fact, even against the MERS COVID viruses, it is effective. So it shows in a phase 2, that is in the early preclinical phases, that this is an effective molecule, at least in the lab. Now, these are the phase 2 trial. This is a phase 2 dose ranging study to evaluate the efficacy of molnupiravir in a double-blind randomized trial, which is with RT-PCR, conducted in the US. And they were randomized if the patient had signs or symptoms of COVID within the first 7 days and a positive SARS test within 4 days of enrollment. And now you see, this shows that in patients who were COVID-19 positive, at day 3, there was already a benefit in terms of the percentage of patients who were positive for viral load. And it was already reduced to 20% by day 3, and by day 5, 100%, which means that nobody, 0% of patients on molnupiravir were positive for the virus. And I think this is an important thing. Within 5 days, compared to 24% in the placebo group, 0% were positive for the virus within 5 days. And this has implication on spreading of the virus, apart from, of course, recovery. Now, here's another phase 2 trial, which looked at now different doses of molnupiravir, and they were randomized versus placebo. And the primary endpoint is time to viral RNA clearance. And we can see here that these are all positive at the beginning of the study. By day 3, infectious virus was seen in only 1.9% of the 800 milligram molnupiravir group, only 1.9% versus 16% in the placebo group. Okay. And by day 5, virus was not seen at all in the 400 and the 800 milligram group versus 11% in the placebo group. So clearly showing that this molecule is able to clear the virus from the system as detected by RT-PCR very, very early by day 3, and by day 5, it's completely gone. So we've shown 2 studies to that. Time to clearance of viral RNA was significantly reduced very quickly in molnupiravir. Participants who were negative for antibodies, that means at the baseline, they had no immunity. Reduction in the time to clearance was 4 days versus 27 days in the placebo group. So this, I think, is a very significant difference. And proportion of participants who achieved SARS-CoV-2 negativity by end of the study was also greater. 92% were cleared versus 80% in the placebo group. Again, showing that it acts early and it acts more comprehensively and completely. Now, this is a phase. So this is a phase 3 trial. Now, this is very interesting. This is in early use patients who are non-hospitalized, lab confirmed so they got the diagnosis within 5 days. So this is a very early subsection. And these are very early symptoms and diagnosis within 5 days of getting the treatment. This is a subgroup whom we would treat because this was the group that was at increased risk for severe illness because they had the following risk factors. They were elderly, they had active cancer, chronic renal disease, COPD, obesity, heart conditions such as cardiomyopathy and diabetes. So this is an early group of elderly patients who had multiple risk factors. This is the one you want to hit immediately. And they were given molnupiravir 800 BD for 5 days. Now, you see, this study was done at a time when there were multiple strains. So you had strains against the Delta virus, the Omicron virus, the Gamma strain. Most participants had RNA detected in the nasal, 86%, okay? Some of these, 20% had pre-existing antibody, but 80% had no pre-existing immunity to the virus. And this tells you the story. That compared to, and I think basis of this study, which came in the NEJM just about a month ago, actually just this last month, and I think the approval came basis of this study, that in this subgroup, now which is a subgroup? Early with pre-existing comorbidities given in an outpatient basis, there was a 3 percentage point, which is a 30% reduction in hospitalization or death for the first 1 month after starting the thing. And basis of this study, approval was given. Looking of all the subgroups, I'm trying to get rid of the top bar. 9 of the 10 patients, 9 of the 10 deaths were in the placebo group. Only 1 was in the Molnupiravir group. So in terms of hospitalization or death, there was a significant reduction. In terms of hospitalization, there was a reduction. In deaths, there was an 89% reduction. So clearly, very strong data to say that this molecule seems to work early and in the high-risk group. So looking at COVID-related, again, the same thing, Molnupiravir in terms of hospitalizations, and this is all-cause mortality and COVID-related mortality. In both of these, Molnupiravir seems to work very well. Now, this is a subgroup analysis of the population. Overall, there is a reduction from 9.7% in hospitalization or death to 6.8%. But now going through the subgroups, in the obese, now these are all above 60, elderly, significant reduction. Delta variant, doesn't matter, good activity, significant reduction. Symptom onset, significant reduction. Negative antibodies, patients who did not have pre-existing immunity, again, significant reduction. Patients who had already got moderate disease, there was a reduction. And elderly, again, it was a reduction. Only subgroup that was not helped, and I believe this was not statistically significant, is the diabetes subgroup. So clearly, across all high-risk profiles, there seems to be benefit in using this drug. And again, looking at the variants of concern, Gamma, Delta, and Omicron, in all of them, it is beneficial. The Delta seems to be a little less helped, but anyway, it's helped across all subgroups. In terms of symptom relief, all symptoms are relieved by the use of Molnupiravir, smell, fatigue. So patient can get active much faster and feel much better, much earlier, except for nausea and vomiting. So that's not been helped, and it may be related to the drug rather than to the disease. Now, this is a WHO ordinal scale, which tells you the severity of the illness or the discomfort. And this shows that right from very early, by day 5, there is improvement, and significant improvement. And as you go further, the sickness scale is much better in the Molnupiravir group. That means they feel much better, less sick, very early in their disease. Now, this is a summary of the efficacy. Let's look at clinical outcomes. So this is essentially a revision of what I have just said. Molnupiravir significantly reduces the risk of hospitalization or death through to day 29. 9 out of the 10 deaths that happened were in the placebo group. Molnupiravir is associated with improved clinical outcomes based on the self-reporting. So clinically, less deaths and patient feels better. So mortality and morbidity are both benefited. In terms of virology, Molnupiravir is associated with lower SARS-CoV RNA by day 3, and by day 5 it seems to have gone, and reduced percent of participants had the infectious virus, and that has been demonstrated in multiple studies. What about side effects? The side effect profile seems to be very good. Very compared to placebo, no major difference in the side effect profile. So similar incidence of overall adverse effects and low incidence of individual adverse effects. Lower incidence of drug-related side effects and deaths in the participants of the Molnupiravir group. Important, no evidence of hematological toxicity, no safety concerns. And based on all of this data, Molnupiravir has been approved for adults above the age of 18 who are early in the disease, whose oxygen values are yet very good, but they have a high risk of progression of the disease, including hospitalization or death. So in that subgroup who you think is going to be is early but going to progress, that's a subgroup you would use 4 capsules twice a day for 5 days. And the best part, no adjustment in kidney or hepatic. You know that we don't use remdesivir in hepatic problem, in renal problems. We don't use favipiravir for liver problems. So that we don't need to worry. No dose adjustment based on the age or comorbidities. No drug-drug interactions as per the reported data that I have presented to you. It can be taken before or after food and should be started early. Now, in subgroups, pregnant women, not recommended. Lactated women, not recommended. And after stopping it, 4 days gap before we start the breastfeeding again. No dose adjustment in hepatic and renal, and not authorized for children below 18. Comparing Molnupiravir with favipiravir, and four capsules twice a day, so 800 milligrams twice a day. Favipiravir is a little more complex, 800 milligrams twice a day for a longer period of time. Use in the elderly, you have to be careful in favipiravir, not so in Molnupiravir. Hepatic involvement, no problem with Molnupiravir, but problem with favipiravir. Renal dose adjustment only in severe with favipiravir, and it's approved across the US and UK. So the question that I started with, is Molnupiravir a game changer? And I leave you to think about it, and we'll take that in the discussions. I can't tell you, but I like you to think a little bit about this. Because we can use it early and it is effective, it reduces morbidity. Unlike remdesivir, which can be only used later, of course, that has mortality benefit. But because it is used early, also reduced morbidity and mortality, reduced infectivity, so therefore reduced cost. And then the question whether, if it can be used safely and very early, prevents viral replication, then like oseltamivir, would somebody like to consider it for prophylaxis? But till the time you decide, I think we have one very effective mechanism for viral intervention, which is so sadly underused, which is the mask. It is the best antiviral. It works against all kinds of the COVID variants of concern. It works against all coronaviruses. In fact, it works against all viruses and bacteria. Please, please, please use it. With that, I'd like to thank you very much for your kind attention, for your participation, and to my wonderful panel colleagues. And of course, I'd like to thank the Sun team and Akash for arranging this. Back to you, Murli. I hope I've not overshot in time.
Not at all, Sanjeev. We could have listened to you for even longer.
You're so kind.
I think the slides have made it fairly clear. Molnupiravir is an excellent drug. It gives you up to 90% or even higher reduction in the hospitalization and death if used early. So there are a couple of ifs here, and I'd like to start the questions with them. I request all panelists to come in. I may start with one, but if either Professor Mahashur or Professor Tripathi has a point to make, please do come in, irrespective to whom the question is asked. And of course, Sanjeev, you're the one who can, talk to any part of it. So two caveats on this. One is it's got to be used early. The second that we saw is it cannot be used when the person has become hypoxic, which by and large is after day 5. So that's kind of covered by the first one. But all the studies, including the move out study, have been done before the Omicron variant surfaced. And that has now become the main variant of concern. So, I think more than 75% of illnesses, COVID illnesses in the United States and the UK are due to the Omicron variant. We are probably heading the same way in India too. As I mentioned earlier, Bombay is, information first. Are you going to be able to use Molnupiravir in the Omicron variant? How effective is it? I'll start with Sanjeev. You've done the maximum reading, and then go on to Professor Mahashur and Professor Tripathi.
Yeah, thank you. I think very pointed observations, and I appreciate that. The answer is that because Omicron is so recent, in fact, this, the NEJM article was published in December and Omicron came in December. So we will not really know. But let's look at the earlier preclinical data. This molecule seems to work across a whole spectrum of the coronaviruses, and particularly the COVID variant. It's been studied across all other variants. Logically, if I can fool the virus by giving it a different substrate and then induce it to make mistakes, then it should work. Now, there hasn't been enough time, but I think it will. Part about the other thing about the early, I think it makes sense to have used it early because it's oral. The gap was in the early. Late, we already have remdesivir. And also, again, I think the manufacturers did a very smart thing. The viral phase is early, isn't it? The later phase is inflammatory phase. So you want an antiviral that will work very early, because at that time, you're not going to use the steroids, the anti-IL-6s, the remdesivirs. So it fits very beautifully in unmet need, which was to prevent the virus from going early. So I think it seems to be doing that bit. So I hope it will work.
Thanks, Ajit. Professor Mahashur?
Yeah, I think as Sanjeev said, it's an antiviral drug. So it's most effective during the viral phase of the disease. Therefore, it has to be used within 5 days. Now, when we talk of Omicron, it's a milder disease and most often a self-limiting disease. So whether to go in for the drug would depend on patient's condition and symptoms. But definitely I would use it for patients with Omicron who are elderly, who have comorbid conditions, and who are expected or likely to go into severe respiratory failure, or their disease would deteriorate. There definitely this is a good drug to be used early in patients who are at risk of progressive disease. That's my view on that.
Thank you, sir. Very succinct, very clear. Dr. Tripathi, can I ask you for your opinion on the same? Dr. Suryakant? He doesn't.
Hi, Murli.
Hi, good evening. Yes, sir.
Hi, कैसे हैं?
ठीक हो? I hope you're well too.
Yeah, fine.
Yes, I was asking you the same question that I posed.
So you want my comment? Okay. So I think I must congratulate to Dr. Sanjeev Mehta, who has always, as he always does, beautifully summarized the whole story. And Dr. Mahashur is always like a decent figure, the father figure in this our fraternity. So I think considering the comments of both people, I'm of the opinion that considering this Omicron infection, which is having more infectivity rather than virulent or mortality, I can maybe use this drug to cut the chain of transmission. Because it has been seen that Delta virus, that the number of the Delta virus is spread, actually doubling time for the Delta virus is around 9 days, while doubling time for the Omicron is only 2 days. So I think it's more infectious, and that's why we can use an early stage to cut the chain of transmission. That can be a wonderful use of this drug. Of course, other than what Dr. Mahashur has really mentioned, that in elderly, in the diseased people, where you have the risk of hospitalization or death, there can this also be used. But I see this drug as an early use for cutting the chain of transmission. Because if you can cut the infectivity within 3 days, it's a very important help. Because even if you see in my Uttar Pradesh has contained very effectively in last 2 years. But if you see on 25th of December, there were only 25 cases reported in Uttar Pradesh. But on 31st of December, we report 250. So within 5 days, 10 times increase in the number. Although the figure is very less, but it is the time, if you see the manifold increase, that is the 10 time increase in within 5 days. So I think that can be one of the important use. But for this, you don't require Dr. Suryakant or Dr. Murli or Mahashur or Dr. Sanjeev Mehta. I think the Sun people have to work hard. You do a lot of sensitization program for the primary care physician, family physician of this country, because at this stage, early stage, they will get the case, not we. We are the tertiary care center. Okay, thank you.
So one of the things that has also emerged with Omicron is that it's very mild disease. Out of these patients who came to you, 250, there may actually be twice that number sitting at home, not visiting the doctor, and that's one of the big worries. And of course, something that's always worried me, and I think all our panelists, we were having a small discussion before we went live, is that the greater the transmission, the greater the number of virus replication, the greater the risk of mutations. And the greater the risk of the mutation into a more virulent form of the virus. And that's always worrying for us. It sounds, and people have been saying, maybe Omicron is a game changer. It'll induce widespread herd immunity very, very rapidly. But that's not necessarily the final story. We may be heading into something more dangerous. So it actually makes sense to rely on a vaccine, not use Omicron as a vaccine, cut down its transmission, cut down virus replication as much as you can. And that's what Molnupiravir, as Sanjeev showed us, is very effective at doing. One of the other questions I wanted to address is, I'd asked the question on Omicron and whether Molnupiravir will be effective. There is some evidence that it may not be as effective, but we don't know yet. And there's no reason it should not be effective, because the Omicron is different because of the variation in the spike protein. And Molnupiravir is not working only on the spike protein. It's working on a range of the RNA of the virus. So theoretically, we would expect it to be just as effective, no matter what the strain, as Sanjeev started off telling us. Okay, so I think we'll only know as time goes on. Sanjeev, as you said, I think this paper came out on the 16th of December, just 15 days ago, and it's already available in the market. I mean, COVID-19 has been a game changer in more ways than one. It's not just Molnupiravir. I don't know any other disease where drugs have been designed so quickly, vaccines have been designed so quickly, and reached the market so quickly. So good things, some good things have come out of COVID-19, a lot of bad things, of course. My next question is to Professor Mahashur. Sir, when you have started treating Omicron variants, and how easy are you finding it to identify the Omicron variant, and how easy is it to treat the Omicron variant? I mean, are you treating it any differently from other variants that cause COVID-19?
I think that's the very important point. Picking up, diagnosing the variant is extremely difficult, because we may not be able to make out whether it is a Delta or it is just Omicron. The reason is we do not have that facility available to differentiate yet. But soon I think it would be developed, then the things would be easier. Currently, most of the times, patients with Omicron have a milder disease and they become symptomatic very fast and respond also very fast, less likely that they're going. But it is the presumptive treatment. Like today, since we are in the wave of Omicron, we would first suspect Omicron. And if the patient's symptoms are very mild, it would characterize only with symptomatic treatment and cutting of the transmission. These are the two aims we would have. But if we suspect or the patient's condition is little bad, then we would go in for monoclonal antibodies or remdesivir, etc. So it all depends on the clinical judgment. But as you said, diagnosing it, differentiating it is a bit difficult, and we have to put our mind into that because at the moment we do not have the lab facility to differentiate. That's it.
I think at the moment there are only 10 facilities with the INSACOG that are doing the gene sequencing.
Yeah.
There are moves to bring in a simpler test, the S-gene dropout test, which may give us an answer faster. But at the moment, I don't think, most people in the country can get it done. And if we can get it done, we're not getting the answers back quickly enough. We certainly won't get it in the first 4 or 5 days after the symptoms start. So I think, as Professor Mahashur said, it makes sense. Try and identify it, do the testing when it becomes available, but start treatment immediately. Let's break this chain of transmission, as Professor Suryakant said. My next question is going to be to Professor Suryakant. Dr. Tripathi, you mentioned that there has been a greater, at least a tenfold increase in the number of cases of COVID-19. Do you have any sense for what number of these were the Omicron variant and what were the older Delta and, other variants that we saw earlier? Of course, the Mu variant, we've not been able to really talk about very much because we haven't been able to, it doesn't spread as fast as far as we know. So how are you identifying these patients? Do you have the facility to do the gene sequencing? How else do you, identify it? Is it purely a clinical diagnosis at this point?
Actually, I'm 100% agree with Dr. Mahashur. We are under-diagnosing Omicron. Why I'm saying? Because Uttar Pradesh is having a population of around 24 crore people, 240 million. And we have only one center, that is our center, King's George Medical University, to which I belong. I'm heading the Department of Respiratory Medicine here. So this is the only center where genome sequencing can be done. And of course, ultimately, final diagnosis of Omicron can be made. The problem is that in Uttar Pradesh, we are doing 2 lakhs testing per day. And you see, what is the usual dictum? That more serious patient sample, they are being sent to our site, not the mild symptom cases or the asymptomatic cases, they are being sent for us because there is no sensitization that you have to send the milder infection disease. So probably we are under-diagnosing. This is true because only a few centers, as you rightly mentioned, only 10 genomic centers are available right now in the country, which can confirm the genomic sequence of Omicron. Until we are not getting a simpler test, I think probably ICMR is in the process of validation and, of course, a recommendation that test. They are in process of that. And I think then only we'll get, because what happened before 25th of December, the cases were 7 to 8,000 cases per day in India. But what happened in last 5 days that they have become 16,000, just double. So it is not because of the old Delta virus that is there. It was very much there. Why it was only 7 to 8,000 for last 2 months, only 7 to 8,000 cases per day. And that is too limited to the Kerala and Maharashtra mainly. Why other states and even now rapidly 23 states are having the presence of Omicron. So I think this increase, I think this is mainly because of Omicron, not because of other variants. And we are not cope up, of course, with the diagnostic efficacy. So this is, I think, Dr. Again, I will agree with sir, that we have to, of course, rely on our clinical sense, which is, you see, always a very important thing. And I think, yes, this drug can be used in early phases, irrespective of the strength. Why should we go into the debate, or why should we go into the headache for getting the genome sequencing done? How this primary care physician will manage to have the sample be sent at King George Medical University or the rest of the other 10 centers. I think we should have the sensitization of now the family physician, the primary care physician, every medical fraternity, those who are involved in the COVID practice, that yes, irrespective of the variant, irrespective of the strain, we must utilize this drug for breaking the chain. So ultimately, because this, I am of the firm opinion that the increase in last 5-6 days, it is all because of Omicron.
Great, sir. Professor Mahashur, you wanted to say something?
Yeah, I fully agree with Dr. Suryakant. I think I have two things, two comments to make. Number one, by sending for genome sequencing at long distances, we are missing the bus. The drug needs to be started early, which we may miss, number one. Number two, whatever the figures are reported are definitely underreported, because the disease is so deceptive. Symptoms are deceptive. And those who are not keen to do the testing may not be diagnosed at all. They can only spread the disease. So that's the care we have to take.
Absolutely. I believe in Europe, what is happening is people are doing a lot of lateral flow tests. It's like a card test. And when they test positive, they stay home. They don't even go and get tested. So the numbers worldwide are probably terribly underreported. Sanjeev, you wanted to say something?
No, I completely agree with the excellent comments of Dr. Mahashur, Dr. Suryakant. He's hit the nail on the head. It's going to be Omicron because that's the only one, which is circulating. And frankly, it makes no difference. You can't waste your time, energy to get too academic about the whole thing. Get on with it, treat it. And I think we need to treat it aggressively. He's right. Get the family physicians in using this drug. I said that at my last slide. Maybe we should use it very early to cut the viral replication so we can prevent the spread. So I think all the panelists, yourself included, are saying the same thing. Get on with it, treat it. It's severely underreported. Most patients, listen, my own daughter had a cough and cold in the US and she told me, Dad, it's nothing. I told her, I got a cold. I said, darling, get yourself tested. And sure enough, she was on the lateral flow test positive. She's not reported. She's the third vaccine. She got a little symptom. She's fine. Her roommate is. Nobody is reporting it. They're doing the lateral flow, sitting at home, perfectly okay in 3 days' time. Done. And that's the majority of the patients.
So I'm going to take you to another content. Sorry, Professor Mahashur, you wanted to say something?
Sir, this is Sanjay, sir. So I just, can I ask one question?
Yes, please. Yeah.
Yes, sir. Sir, considering we are talking on Omicron, sir, just wanted to understand from an Indian scenario, what is the prognosis in Indian cases till now, although the number of cases have been only in hundreds or thousands. And what are the challenges in managing this Omicron variant?
Whom shall we start with?
Well,
Dr. Suryakant, yeah, you've had quite a few patients recently. So what are the challenges?
Sanjay Chaudhary, actually, yes, we have the most important challenge of breaking the transmission, breaking the chain of this. This is the most important challenge. India is a country of celebration, jubilation, festivals, and crowd without any purpose. I will not comment on the political rallies, of course. That is also time. The 5 states are undergoing the election, So there is a crowd and crowd. I released a video in Hindi. उसमें मैंने कहा है कि भाई एक काम कर लो कि भीड़ में ना जाओ और ना भीड़ जुटाओ. मतलब don't go into the crowd and don't invite the crowd. So, but who will listen me? who will listen me when I will say that don't invite the crowd. The problem is this, that we cannot avoid this situation. And that's why cases are bound to increase. The only thing which we have, which is of concern is, which is only challenge Dr. Sanjay Chaudhary is that these cases, increase in cases, should not convert into the chaos, which happened during the Delta wave this year in 2021 in March, April, May. Now, Dr. Mahashur has rightly mentioned, we have to protect our elderly, we have to protect our disease fellow, because these people will create chaos. Even the less virulence, which is till date, it is said that Omicron is having less virulence. But this less virulence may be hazardous for elderly and for the diseased people because they are having very low immunity. So we have to protect these people. You, my dear friends, there are 11 crore people above than 60 years in this country. And there are crores and crore other people who are having more than...
You got muted, Dr. Suryakant. Ab mute ho gaye. For some reason, you got muted.
Dr. Suryakant, you're muted still. Dr. Suryakant, you're muted.
Sir, mute. Sir, can you unmute yourself, sir? Dr. Suryakant, sir?
Dr. Suryakant, you're muted.
Appropriate behavior. Otherwise, we won't be able to, of course, contain the number of the cases. And ultimately, till date, we have 1,500 cases reported till date. This is the latest data which I have just seen from my office. Latest report is that 1,500 cases we have in India of Omicron, with the only 10 genome sequencing labs reported till date. I don't know how many there. And only one death has occurred. So till date, the mortality is around less than 0.1%. But what will happen when more and more elderly people will be infected, more and more diseased people will be infected? We don't know. That is the only challenge.
So since Murli, you were saying Mumbai leads in terms of numbers, I'll just
Sir, Mumbai always leads in every number.
It's a very unfortunate thing, but I'll quickly share. We were down to 6 patients in the ward and probably 2 in the ICU about a week ago. Our ward has gone completely full. We've opened a new ward as of today. We have a municipal center next to us which had shut down, fully completely packed now with 70 patients. Our ICU is being expanded. So that's exactly the point that Dr. Suryakant was making, that the surge is happening. And as the number of patients fill up in the wards, the ICUs are getting full. I just was answering a question. All my patients are now above 75. All of them have multiple comorbidities like heart failures, pacemakers, kidney cancers. Everyone is a real high risk, and they are a bomb waiting to explode. They would have suffered badly anyway, but with a little push from COVID, they're going to go over. That's that big subgroup that Dr. Suryakant was saying, 110. Unfortunately, so far, I've not been getting our ILDs and others. As it becomes infectious, these poor people who've been so safe till now are going to get their infection. It's going to be a bomb. It will explode. So we need to move very quickly and not be complacent. And I think we should really stop these people from saying, oh, it's a vaccine. It's not a vaccine. It's a vicious disease. And one should not be fooled. I think that message has to go home very, very strongly.
Absolutely. Can't agree with you more. The word that really everybody should take home is don't be complacent, because that has unfortunately crept in. There's also a lot of tiredness. That's the other challenge, Dr. Chaudhary, we are facing, that after 2 years of, being strict and not going out and wearing masks and so on, people are just getting tired and say, we'll take what comes. And that I think is very wrong. If we internalize it, we make it a way of life. And that's what we need to do, like the Japanese have done, like the Koreans have done, even before COVID-19. use of masks in public was kind of part of their culture. We need to make it a part of our culture. And then to make that change is, to my mind, the biggest challenge of all. One of the things that we've
sorry, Murli, everybody is masked here. Sorry, Murli, I had to interrupt. Everybody is masked in Mumbai, so don't make any mistake. The masks are only on the neck, so we have great neck.
Yeah, as they said, the virus came from the chin, so we'll wear it on the chin. So basically, the why we had it the second wave is the way it rapidly spread in whole families, which was not what we saw in the first wave. We are seeing the same happening now. It's even more, rapidly spreading through families than the second wave did. And as Sanjeev rightly mentioned, the challenge is to keep the vulnerable safe. And that we don't know how it's going to affect them. A few small challenges we're going to face again is we have been using in this very vulnerable population the antibody cocktail. We don't know if the antibody cocktail is going to work, the current antibody cocktail is going to work as well against the Omicron variant. So I'm going to go to our panelists. Professor Mahashur, do you have any information on how effective, the old cocktail, that is Casibirivib, Imdevimab, I can't pronounce these, the Regeneron cocktail, how effective it is against the Omicron variant?
Well, cocktail is effective. But what I see today is it is being overused. I think the cocktail role comes when the antivirals fail, or little later in the disease and patient has symptoms which are persistent and he is likely to deteriorate in front of you. Or suppose there is a patient who has cold and cough and fever. If his fever does not go in 2 to 3 days, I think the cocktail therapy should be considered. Quite effective, no hospitalization, 1 hour to 1.5 hours injection. Of course, the cost is a little more, but after that, he is assured that the disease progression might curtail. So it is effective, but if we have an oral medication which could be administered early, then we may not need the cocktail therapy for these patients. Therefore, I would always have my opinion in favor of oral antivirals administered early, and they're quite safe also.
Absolutely, couldn't agree more. Oral administration can be administered at home, far less expensive. The question of are there side effects is the one we need to tackle now. So Dr. Sanjeev Mehta, I'm going to come back to you. I know you showed that it seems to be reasonably safe, but we always are worried when something is working on genes, is mutagenic, which is how it works. What is the safety profile of Molnupiravir? How safe is it to use? You've already said it cannot be used in pregnancy. What other precautions need to be taken given its mutagenicity?
So, good question. And, I always tell when I speak that when the speaker says it's a good question, it means he doesn't have a good answer. So, yeah, so good question. So, Murli, you've hit the nail on the head. I don't know. The data that I've shared are the data which are coming from the, the studies that were presented. Seems to be good. There's no black box warning from the FDA, both the US and Europe. So far, so good. But, when you use it in, say, maybe 1,000, 2,000 people versus when you use it in 1 million people, which is what it is going to be, I think we should have a phase 4, post-marketing surveillance that will warn us. I think we cannot let our guard down. You've absolutely accurately said that it may work on genes, maybe mutagenic, really don't know. But at least right now, it seems safe. I think right now, the initial data is good, that it can be used even in patients with comorbidities. And I think we should not go overboard. Use it only as that study shows in the elderly with a high-risk profile, not likely to be pregnant, not likely to be lactating. Then let us see what happens. But we need to keep our guard up.
Absolutely.
And I think the age, below 18, they are not yet recommending.
Absolutely. The other suggestion is that when a person is on molnupiravir, they take precautions as far as the possibility of impregnating the the partner goes. So precautions, and like they've said for the lactating mother, do not feed for at least 4 days after completing the course. We would probably advise using all precautions, contraception precautions, for at least a month or so after a course of molnupiravir. I think it makes sense. Having said all that, it predominantly works on RNA. It doesn't seem to work so much on DNA, partly because it works on uridine rather than thymidine. But it also works on cytidine. So, as you very clearly showed in your slide, Sanjeev. So we need to be careful. It's a very effective drug, but like all effective drugs, it always comes with a certain sense of unease when you're using it. But so far, the safety data seem very promising. In terms of ordinary side effects, I think they usually talk about the ones, headache and nausea and vomiting that can happen with any drug. But given I've almost never used favipiravir, it was not a great favorite in Bangalore. I haven't even put it on my hospital protocol. We left it as very reluctant. If you want to, you can use it. But I know it was very popular in Mumbai. So if you had a choice between favipiravir and molnupiravir, you have listed out the advantages and disadvantages of each. But if I put it to you today that, is favipiravir safer than molnupiravir if there is no renal or hepatic issues, which would you be tempted to use? Again, question to both of you, Professor Mahashur and Sanjeev.
So I've used a lot of favipiravir, and the logic was simple. It may or may not be great. We don't know what the efficacy was. But if it can reduce some viral replication, then so be it. Something was better than nothing in terms of, and it was pretty safe. I mean, in the patients we used it, a few we monitored very closely their kidney and liver profiles. And apart from getting a little high uric acid, a little increase in liver transaminases, it was good. And of course, we took the precautions. No lactating ladies, no pregnancies and all. We didn't have any major problems. What was a big problem with favipiravir was the absolute irritation with the doses. So there was a huge irritation that the patients had. Oh, 1800 milligrams first day, second day. What if I take it at night? What if I don't take it tomorrow morning? Which dose? It was a chaos. Finally, I got so sick of it that in my prescription, I would write 800 milligrams BD for 7 to 14 days. Forget the loading dose because it became more difficult to explain it. Given that, and the fact that the data seems to be stronger, my first choice would be molnupiravir right now. It seems to be safe. There's no dose adjustment. I don't have to worry. Easier for the patient. That's my first choice.
And the data on efficacy is far stronger.
Far stronger.
Professor Mahashur, anything to add to that?
Well, I agree with what Sanjeev has said. Since there is no experience just now about molnupiravir, I think favipiravir has been found to be very effective. There's no doubt about it. But the dosage was the main issue. Therefore, the compliance was little difficult from the patient's point of view. These are the things we faced. But efficacy-wise, it looked similar. Unless I have the experience with the newer molecule, it may be difficult for me to compare the two. But I think efficacy-wise, I would say favipiravir did its job quite well. But later on, I don't know why, we stopped hearing about the molecule because people stopped using it. Maybe the reason was people approached the hospitals late Test results take time to come. By that time, certain patients go into a little more serious stage and had to be hospitalized. But early cases definitely responded.
I agree.
The ones who started to improve before that didn't feel the need to take it. That was the other thing. I'm going to come to Dr. Sanjay Chaudhary, who had his hand up, but I'd like to add a very, in my opinion, what is very important. The duration of Omicron illness seems to be much shorter. And when you start Molnupiravir, the symptoms recede even more rapidly. However, I think it's extremely important that patients complete a full course, because like any antibiotic or antiviral, if it's taken in suboptimal doses, subtherapeutic doses for a shorter period of time, the chances are that it will actually induce mutagenesis. This is a highly mutagenic drug. So you'll end up with more dangerous mutations if you're not careful. So I think, again, a challenge for the Sun team and all the other teams, which are marketing Molnupiravir, is that the full course in a full dose should be taken. After all, it's just 5 days. Please take the full dose. Do not stop too early. In our country, that has always been a challenge. And I think it can only be overcome by a proper education of doctors and patients. Dr. Chaudhary, you had your hand up. Can I request you to use, whatever you wanted to use?
Hello. Yeah, I'm Dr. Prachi, and I'm from Medical Affairs team at Sun Pharma. So thank you so much, our experts, for wonderful comments on Molnupiravir and about COVID scenario. So we have a lot of questions from our audience, and so can we take those questions, sir?
Absolutely. Are you going to read them out, Dr. Prachi?
Yeah, sure, sir.
Yeah, please go ahead.
Okay. So the first question is whether Molnupiravir is recommended in moderate to severe cases of COVID-19 associated with comorbidities.
Well, the strong indication is mild to moderate disease, not severe at all. And if you give it early, that is during the viral phase, it definitely works very well. Therefore, it should not be given in moderate to severe cases as a first line.
Right. So, any other comments? Anyone would like
one
to
of the
add?
things we've learned in the first two, waves, and from data worldwide, is people have used antivirals too late. That has given the antivirals a bad name. It's like they don't work. We've learned that with remdesivir. The West rubbished remdesivir. We used to find it very useful. And it was a big problem to convince people that, yes, remdesivir is useful. I think the same mistake was made with ivermectin. We recently have looked at our own data and found that ivermectin is actually pretty useful. The problem is that they've used it late. And now with the new pine tree data showing that if you use remdesivir early, for 3 days, just 3 days, within the first 7 days, you're getting very, very good results with remdesivir also. So I think the challenge is not, to use it late, but to use it early. Don't make the mistake of using it late. Late inflammatory phase, use anti-inflammatory drugs. Early viral phase, use the antiviral drugs. That message should go across again and again because it's somehow to be internalized.
Right, sir. Thank you so much. I
agree. I think the point that Dr. Mohan was making is so important, because by the time you reach a late phase, the virus is gone. So that is why it was really studied and approved in the early phase.
Right, sir. I hope our audience has got their answer. So my next question is, sir, after what age can it be given? That's what the audience has raised a question.
It's in the slides, 18. So I'll go quickly. Sorry.
Yeah. Okay. And the next question is it advisable to give Molnupiravir after 5 days of symptom onset?
No. It was clear in the slides.
Yes.
It works well in viral phase and before 5 days, maximum 7, but recommendation is 5 days.
Right, sir.
I'm going to amplify that, what Professor Mahashur added on. So it's recommended in the first 5 days. But very often by day 7, and something like Omicron is moving faster, we may be getting into the inflammatory phase by day 6 or day 7. The patient is already hypoxic. We would be using steroids, as recommended by the recovery trial, for example. At that point, when we are in this overlap between the viral and the inflammatory phase, I would probably start using Molnupiravir along with the steroids. I don't see a problem with that. But the recommendation is first 5 days.
Murli, what would you think that by the time the patient got into the hospital on day 7 is not doing well, would you then switch to remdesivir? Because that's the one which has been used in the... so that may be the one, So what are your thoughts on that?
Completely. Once a patient is in hospital, remdesivir would be my choice. Before the patient comes in, they're dithering, they're not able to get beds. And I foresee that that's going to happen. I think this rate at which this is surging, we're going to get overwhelmed. There'll be no beds available. Many of these people will have to be treated at home. That's what the US and the UK are facing now. At that point, I would probably use oral steroids with Molnupiravir while we make arrangements to get them into hospital.
Right. Okay. So the next question is it advisable to give Molnupiravir and remdesivir together in a patient who are at high risk?
Don't burden the patient financially, because it's not going to help. One works in the early phase, the other works in the moderate to severe phase when the symptoms have progressed. So therefore, going back to a drug where there is no virus, it's mainly the inflammation, then remdesivir is a better drug because the symptoms can be taken care of. It's more effective in the moderate phase. So patients who are hospitalized, I think remdesivir is the preferred drug. On the OPD basis, with early diagnosis, I think Molnupiravir is a better drug. So don't combine.
So, Prachi, there's no data. I see the point. Like we use 4 anti-TB drugs. I think somebody is thinking that maybe we should use 2 antivirals because they work at 2 different phases. That may be the thought that the doctor who has asked this question has. But Professor Mahashur has very rightly said they work at different phases, and we really have no data to see if they combine well. Logically, like we may think about it, but I think at the moment, as a panel, we cannot recommend the use of these 2 drugs together.
And there are no studies to confidently quote about it.
Yeah.
I mean, I completely agree with my fellow panelists. Whenever you combine drugs, 2 things can happen. They can work synergistic, especially they work on different sites. But they could also antagonize each other, and you'll be adding on adverse effects. At this point, I mean, that's a very good question, but I think at this point we cannot. I mean, as Sanjeev very rightly observed, when we say it's a good question, it means we don't have a good answer. And I think at this point, that recommendation cannot be made.
Right, sir. Thank you so much for this answer. It was much... So, what are the common symptoms that are seen with Omicron?
So what we're reading is that it's very mild symptoms, mild fever, sniffles, a mild cold, a mild sore throat, and then the person rarely goes into hospital. I was on a panel discussion where one of the other panelists was Dr. Radha Sundaram from Glasgow, an intensivist, and she had this, observation to make that they're getting a lot, but most patients are in the ICU for a day and then they're out. We're not seeing patients in the ICU for a week, 15 days, a month, like we had in the second wave. Patients are coming in and going out, even the vulnerable patients. So, the point she was making is the symptoms are milder, but otherwise really not much to differentiate Omicron from the other variants. So as has already been discussed right in the beginning, mild symptoms, but really it's impossible to differentiate, treat everyone the same at this point in time.
Can I add something? See, it mainly affects the upper respiratory tract. And as Murli has said, that the symptoms are related to upper respiratory tract. Why? because the virus multiplies 70 times more in the upper airway than in the lower airway, where it multiplies just 30 times. Therefore, the patients in this particular condition have mainly upper respiratory, and therefore it spreads much faster. That's the logic behind all this. And therefore, the symptoms are mainly restricted to upper respiratory, and that's why I said quite deceptive. We may treat it as a routine upper respiratory tract infection. So do the testing when upper respiratory symptoms occur in these patients. Okay.
Okay. Thank you so much, sir. So another question is, should it be used in asymptomatic cases like contact in the family who are RT-PCR positive?
It's a
Good question.
good question. Like we said, I would consider it. I don't have data, but I would consider it. In fact, that's something we had discussed earlier on, when Favipiravir came, that if it is going to stop it, if it's RT-PCR positive, and I don't think we have an answer. I leave it to a combined vote from the panel. It looks attractive. If it is safe, can be used orally. We don't have data for it.
No, they have not mentioned that it can be used as a prophylactic drug.
Yeah.
There are no studies and no recommendations. It's mainly to treat the virus. So I don't think it may work as a prophylaxis.
And you may miss the boat. You may have to give it. Then you may use it when it's like putting water when the fire is not there, and then when the fire actually happens, you don't have the water because you've already used it. So studies are not there, but
I would have a slightly different point of view, Sanjeev, on that. I think the question was in a person who's RT-PCR positive. So the fire is there. It's not burning out of control, but this is the best time to use it. So I would say in a high-risk individual, not in everybody, let me make that very, very clear.
right.
In a high-risk individual who is RT-PCR positive, has a history of contact or not, I would probably be very tempted to use Molnupiravir early rather than late.
No
if the person
question.
is just a contact and is not tested positive, then we have absolutely no data. I would be very careful. And I think there I would completely agree with Sanjeev that, I'm not going to venture into this and use up a drug that may come in useful 3 days down the line or 5
You are
days.
right. RT-PCR positive, you have to treat it. And I didn't mean that. I meant that a family contact
Absolutely.
without positivity is no good.
I think by definition, an RT-PCR positive would probably become a patient and not a contact. Yeah.
And we're going to see that very, very often with this Omicrons. Many of them are, especially the vaccinated ones, are RT-PCR positive with absolutely no symptoms.
Right, sir. So we have the next question, that is, for doubly vaccinated patients who have come positive, does the treatment plan change in any way?
I don't think so. I don't think so. Only I have a doubt which only may be able to solve, that is cocktail contraindicated if the patient is vaccinated?
No, I think it's fairly clear that the way to do it is to do the antibody test. If the antibody levels are very high, then the cocktail does not seem to make that much of a difference. If the antibody levels are low, then the cocktail seems to make a very big difference. So that's probably the way to go. If a person comes in reasonably early, a contact or otherwise mild symptoms, antibody levels are high, I could probably just wait and watch because it's expensive. On the other hand, using Molnupiravir makes a lot of sense in such a person. As you said, sir, I think the vaccination does not make that big a difference. We know that patients who are doubly vaccinated, in fact, patients who are triply vaccinated are all coming in with infections. Fortunately, these seem to be mild infections, but we don't really know in the high-risk population. So I think, as you said, we should treat them exactly as we treat any other patient.
I completely agree with you. It's a clinical condition of the patient that determines the care, not so much the vaccination status.
Absolutely. Well said.
Okay, so one more question that audience has, and I think Mr. Akash will be able to help. So when will the drug get distributed in the market? When will it be available?
Yeah, so we have already started sending out the drugs to the market. It is in many of the locations it has already reached, and few of the locations it is in transit, and I'm hoping it to reach earlier. So our team members, Sun Pharma team members, will get in touch with all the doctors, and they will inform the availability at the nearest chemist counter to all the doctors. So we are going to get it soon. Yeah.
I understand from our pharma team that it's going to reach us on Monday. So it will start to be available from Monday.
Yeah. So one thing I just want to announce, sir, in continuation with the purpose which we had in the COVID products, where we try to give the products at affordable price, we had announced this in our press release as well. So we are going to offer this product Molnupiravir to all the patients at very affordable price, maybe economical compared to other competitors. It will be priced at 38 rupees per capsule, and it will be costing per course 1,520 rupees to a patient.
Great. One of the things I must point out, which is interesting, is this was developed as a not-for-profit, program. And that's very interesting because no company is interested in pushing it for profit reasons. The design of the molecule, everything came from a non-profit organization. So that's, something to take home when people are, talking about how pharmaceutical industry is using this opportunity to make billions. So that's interesting.
You rightly said, sir.
Murli, the same was said about the original deployment of the RNA vaccines. And I think somebody in pharma forgot that. Yeah.
True, absolutely true.
There's a case against Moderna for that.
Yeah, they got a lot of subsidies and support with, using that as the excuse. Yeah.
But good point.
Okay, so thank you so much. Thank you so much, Dr. Murli Mohan sir, Dr. Sanjeev Mehta sir, Dr. Ashok sir, and Dr. Suryakant sir for being part of this program today. And despite technical glitches, you managed to hold on to the time. Thank you so much to all the viewers who have stayed here patiently for more than an hour. I can assure you that in case there are some questions unanswered, it will be replied. Thank you to our technical team for the backhand support. So let us accomplish what we are here for, healthy citizens and a COVID-free nation. Thank you all for giving your valuable time to make this program a success, and a very happy new year once again. Thank you so much.
Thank you, Murli.
All.
Thank you, Sanjeev.
Good to see you, sir.
Conducted.
Terrific to see you both, Dr. Suryakant, of course, and the Sun medical team and their, ever hardworking, sales team. So Mr. Phalke, Dr. Sanjay Chaudhary, Dr. Prachi, lovely to see you all. Wish you all a very happy, successful, safe and healthy year.
Thank you.
Thank you,
Thank you
sir.
so much.
And
Thank
wish
you.
you
Wish
all
you the same for you.
all a happy new year.
Thank you. Thank you all for joining us.
Thank you.
Good night now.
Recording